Thank you, dear chairpersons, and I would like to thank once again Dr. Belardi and the colleagues of ICBA for this new invitation in this important symposium. What I would like to review with you in the next 10 minutes is recent data from a European registry which was first presented last month in the annual meeting of the ESC. And the aim of this registry is to try to answer two questions. Patients with chronic coronary artery disease, how do they look like in Europe nowadays? And secondly, how do we treat these very high cardiovascular risk patients? And so this registry was conducted in 20 ESC countries, and we started the recruitment in 2015, and it ended last year in July. And we could collect data on nearly 10,000 patients, and what I will present to you today are the data on the 9,000 or so European patients enrolled in this registry. I would like to add that a 2 years follow-up is scheduled, so we will see whether there are differences across the different subgroups. There were three ways of including these chronic coronary artery disease patients. One, patients who were routinely followed up after a history of ST elevation or non-ST elevation mechanical infarction. The second group was patients who underwent an elective revascularization, and the third group were patients who were known to have a documented stable coronary artery disease. We excluded recent ST elevation mechanical infarction patients because they are very different from the rest. These are the different recruitments in the various countries, and we were fortunate to see that most important European countries were well represented in this registry. What is the clinical profile of European patients with stable coronary artery disease? As you can see, nearly 40% of these patients had an history of ST elevation mechanical infarction, 25% or so non-STEMI, and the rest was evenly distributed amongst patients who were enrolled because of coronary revascularization or stable coronary artery disease. These are the demographics. There was an overwhelming overrepresentation of male patients, nearly 3/4 of our patients. Most of these patients were enrolled on the occasion of a routine visit. The mean age was 67 years, and approximately 15% were over 80 years of age. These patients had a number of comorbidities. I will come back to risk factors in a moment. As you can see, 16% had an history of atrial fibrillation, nearly half a history of heart failure or left ventricular dysfunction, and approximately 5 to 10% had either a lower extremity artery disease, previous stroke or TIA, chronic kidney disease, malignancy, or pulmonary disease. Now, what was the control of cardiovascular risk factors? You can see that it is quite suboptimal because we could observe that nearly 20% of these high-risk patients were current smokers. 1/3 had obesity with a BMI of more than 30 kilograms per square meter. 30% were diabetics. There was 25% of the patients who had poorly controlled hypertension. And finally, 40% or so had an LDL cholesterol above 1 gram per liter, and nearly 3/4 above 0.7 grams per liter. So not very well controlled cardiovascular risk factors. There were some demographic differences based on age, above or below 75 years of age. Elderly patients are in red. You can see that the rate of comorbidities was higher as expected in the elderly patients compared to the younger patients. And this persisted after adjustment for sex and for region. You can see that female patients tend to be older. The older patients had less the lower frequency of obesity. They were more commonly hypertensive or diabetics, and they were more commonly with a history of heart failure, atrial fibrillation, or with any kind of other comorbidities. There were also differences based on gender, and this is the adjusted analysis which is shown to you. Female patients tended to have more often a stable coronary artery disease and less often a ST elevation myocardial infarction. As mentioned, they were older, they were with a higher BMI compared to male patients, and there was a higher prevalence of hypertension, diabetes mellitus, and a lower prevalence of current smoking. Now, how did we treat all these patients? This slide summarizes the main preventive medications or anti-anginal medications before admission in red and after inclusion and at discharge in blue. You can see that 85% or so of the patients were taking antiplatelet agents, 55% an ACE inhibitor, more than 20% an ARB, 77% beta blockers, and the rest, there was also a significant proportion of patients treated by MRAs, diuretic agents. Dihydropyridine calcium channel blockers were prescribed to nearly 20% of the patients, and more so for nitrates. Finally, statins were given to more than 80% of the patients, and you can see that there was a trend that the rate of prescription increased after the admission of the patients or the routine visit of inclusion. However, if you look at the right-hand column, we looked at the proportion of patients who were taking 4 preventive medications, that is aspirin, statins, beta blockers, and ACE inhibitors or ARBs, and you can see that less than half of this very high cardiovascular risk population was taking the combination therapy of preventing medications. These are the adjusted data for based on age, and not surprisingly, elderly patients were more commonly taking anticoagulants, be it an antivitamin K or neural anticoagulant, less likely preventive medications like ACE inhibitors, beta blockers, or statins, and as you can see, the proportion of the odds ratio for taking the quadruple combination was only 0.6 in patients over 75 years of age, and this persisted on the right-hand panel after admission. There were also some gender-related differences, which are shown here. Female patients tended to receive less likely antiplatelet agents and statin than male patients, and on the contrary, more likely a dihydropyridine, a diuretic agent, or a nitrate. So taking all in all, I think that this large European registry with contemporary patients suggests that the guidelines recommended prescriptions are suboptimal, and in particular the combined ACE inhibitors or ARBs, beta blockers, statins, and aspirin prescription was observed in less than half of the patients, although there was a rise in these prescriptions, as mentioned previously, at discharge. There were obviously some differences based on age and to a certain extent on gender, and if we compare this data to what the new version of the guidelines for the management of chronic coronary syndrome, which were released last month also in Paris, I will go through rapidly the preventive behaviors. I told that there were a number of current smokers, and regarding LDL cholesterol, you know that the ESC has issued new threshold with a goal of less than 55 milligrams per deciliter for patients at very high cardiovascular risk, and this was the case of this registry. So there's a long way to go in order to improve the situation, but maybe we will discuss that during the discussion. So in summary, I would like to say that this large European contemporary registry of patients with chronic coronary artery disease show that prevention treatment remains suboptimal. However, we observe some improvement in the rate of prescription of recommended medications after inclusion, particularly with regards to statin prescription. We observed gender-related and age-related demographic differences in our population, and the follow-up of 2 years will tell us whether these differences impact on clinical outcomes and whether the treatment characteristics, which once again are suboptimal, influence clinical outcome. Thank you very much.